Now that we have discussed the diagnostic framework used to ensure accuracy and consistency, let us begin examining the individual diagnostic pathways, starting with fasting plasma glucose, commonly referred to as fasting blood sugar. Fasting blood sugar measures the concentration of glucose in the blood after a patient has had no caloric intake for at least 8 hours. This fasting state is critical because it reflects the body's baseline glucose regulation without the influence of recent meals. According to established guidelines, diabetes is diagnosed when the fasting plasma glucose is 126 mg per deciliter or higher. Values below this but above normal indicate impaired fasting glucose, which we will discuss later when we talk about prediabetes. At this point, you may ask, why is fasting blood sugar often the first test requested? From a laboratory perspective, FBS is simple, cost-effective, and widely available. It requires minimal patient preparation compared to other tests, and it is easy to standardize across different laboratories. This makes it ideal for large-scale screening and routine clinical use. Let us consider a laboratory-based example. A patient reports to the lab in the morning after fasting overnight. Their plasma glucose result is 132 mg per deciliter. This value meets the diagnostic threshold for diabetes. However, before confirming the diagnosis, the laboratory and clinician must consider whether proper fasting was observed, whether the sample was collected correctly, and whether any acute illness could have influenced the result. This leads to another important question. Can a single fasting glucose result confirm diabetes? In most cases, no. The diagnostic framework recommends repeat testing on a different day to confirm the finding. This helps rule out transient hyperglycemia due to stress, infection, or pre-analytical errors such as incomplete fasting. From a laboratory operations standpoint, FBS is also sensitive to pre-analytical variables. Delayed sample processing can lead to falsely low glucose values due to glycolysis. This highlights the importance of using fluoride-containing tubes or ensuring prompt plasma separation. You might then wonder, if fasting plasma glucose is so useful, why do we need additional tests? The limitation of FBS is that it reflects glucose levels at only one point in time. Some individuals may have normal fasting glucose but experience significant post-meal hyperglycemia. In such cases, fasting plasma glucose alone may fail to detect early diabetes. Therefore, while FBS is an essential and widely used diagnostic tool, it does not capture the full picture of glucose metabolism. This brings us to an important question that we will explore in the next slide. What happens when a patient has a normal fasting plasma glucose but still has impaired glucose handling after a meal or glucose challenge? In the previous slide, we ended with an important question. What happens when a patient has a normal fasting plasma glucose but still struggles to handle glucose after a meal? This is precisely the clinical situation where the oral glucose tolerance test, or OGTT, becomes especially valuable. The OGTT assesses the body's ability to respond to a controlled glucose challenge and is recommended when fasting blood sugar results are borderline, inconsistent with clinical findings, or insufficient to explain symptoms. The test is performed after an overnight fast. A baseline fasting sugar is measured, after which the patient consumes 75 grams of oral glucose and blood glucose is measured again 2 hours later. Diabetes is diagnosed when the 2-hour plasma glucose value is 200 milligrams per deciliter. At this point, a common question is, why does the OGTT detect diabetes that fasting glucose may miss? The reason is that early abnormalities in type 2 diabetes often affect postprandial glucose regulation fast. Insulin resistance and delayed insulin secretion may not significantly elevate fasting sugar, but they become evident when the body is challenged with glucose. Let us consider a laboratory-based example. A patient presents with fatigue and a family history of diabetes. Their fasting blood sugar is 104 milligrams per deciliter, which falls within the impaired fasting glucose range but does not confirm diabetes. An OGTT is performed, and the 2-hour plasma glucose result is 212 milligrams per deciliter. Despite the relatively modest fasting value, this OGTT result confirms a diagnosis of diabetes. You might then ask, when is the OGTT specifically recommended? OGTT is recommended in individuals with borderline fasting glucose values, those with risk factors such as obesity or family history, and in situations where fasting glucose and HbA1c results are discordant. It is also commonly used in special populations, such as pregnant women, although that is beyond the scope of this discussion. From a laboratory perspective, OGTT requires strict adherence to pre-analytical conditions. The patient must be adequately prepared, must remain seated during the test, and must not consume additional food or drink. Failure to follow these conditions can significantly affect results. An important interactive question here is, what are the limitations of the OGTT? The test is time-consuming, less convenient for patients, and has greater biological variability. These factors limit its routine use, despite its high sensitivity. In summary, the OGTT is a powerful diagnostic tool that complements fasting plasma glucose by revealing post-challenge hyperglycemia. Its use is recommended when fasting results alone do not provide a complete picture of glucose metabolism. This naturally leads us to the next question: is there a test that reflects long-term glucose exposure without requiring fasting or a glucose challenge? That question will guide our discussion in the next slide on hemoglobin A1c. Earlier, we discussed the oral glucose tolerance test and its utility in detecting post-challenge hyperglycemia. This brings us to another important question: is there a test that reflects long-term glucose exposure without requiring fasting or a glucose challenge? Hemoglobin A1c, commonly called HbA1c, answers this need. It measures the percentage of hemoglobin molecules that have glucose bound to them, reflecting average blood glucose over the previous 2 to 3 months. Unlike fasting blood sugar, or OGTT, HbA1c provides a broader picture of glycemic control rather than a single point in time. The diagnostic threshold for diabetes is HbA1c greater than 6.5%, measured using approved verified methods to ensure accuracy and standardization. Values between 5.7% and 6.4% indicate increased risk or prediabetes. An important question from the lab perspective is, why is HbA1c considered convenient, and what are its limitations? Hemoglobin A1c is convenient because it does not require fasting and can be performed at any time of day. However, certain conditions such as anemia, hemoglobinopathies, recent transfusions, or severe kidney disease can alter HbA1c levels, potentially leading to misinterpretation. Laboratory professionals must always consider these factors when reporting results. Let us look at a laboratory-based example. A 50-year-old patient has borderline fasting glucose of 112 milligrams per deciliter and a 2-hour OGTT of 198 milligrams per deciliter. The clinician orders an HbA1c, which comes back at 6.7%. This confirms diabetes and provides evidence of sustained hyperglycemia over months rather than an isolated abnormal glucose reading. A realistic interactive question could be, if a patient has normal fasting glucose but an elevated HbA1c, how should we interpret this? This scenario demonstrates the complementary role of HbA1c. It can detect chronic hyperglycemia that might be missed by fasting glucose alone, emphasizing why multiple diagnostic pathways exist. Another important point is that HbA1c can also monitor long-term treatment response, guiding clinicians in adjusting therapy or reinforcing lifestyle interventions. From a laboratory standpoint, quality control, method standardization, and awareness of interfering factors are critical. Without these, results may mislead the clinician and compromise patient care. In conclusion, HbA1c is a powerful tool for both diagnosis and long-term monitoring, complementing fasting glucose and OGTT. It is especially useful for patients who cannot fast or when a snapshot of long-term glycemia is needed. This brings us to the next slide, random blood sugar, which is particularly valuable when patients present with classic hyperglycemia symptoms, allowing diagnosis without fasting or a glucose challenge. Let's deep dive into RBS testing. As discussed in the previous slide, HbA1c provides a long-term view of glycemia. Now, let's consider situations where a patient presents with classic symptoms of diabetes and cannot undergo fasting or an OGTT. This is where random blood sugar measurement is particularly useful. Random blood sugar, or RBS, is measured at any time of day without regard to meals. Diabetes is diagnosed when the glucose value is 200 milligrams per deciliter or higher, together with classic hyperglycemia symptoms such as polyuria, polydipsia, or unexplained weight loss. You may ask, why do we require symptoms for diagnosis with a random glucose test? Without accompanying symptoms, a single high random glucose value may reflect recent meals, stress, infection, or laboratory errors. The presence of classic symptoms increases the specificity of the test, reducing the likelihood of misdiagnosis. Let's consider a laboratory-based example. A patient arrives in the clinic complaining of excessive thirst and frequent urination. Their random plasma glucose is 245 milligrams per deciliter. Even without fasting, this result combined with their symptoms is sufficient to diagnose diabetes immediately, as recommended by ADA guidelines. No additional fasting or OGTT is required in this scenario. A question can be posed. What if the random glucose is high, but the patient reports no symptoms? In such cases, the recommendation is to confirm the diagnosis using one of the other pathways such as fasting blood sugar, OGTT, or HbA1c. This ensures that transient hyperglycemia or pre-analytical errors do not lead to misdiagnosis. From a laboratory perspective, attention must be paid to sample collection, handling, and timely analysis. Delays, hemolysis, or improper storage can affect plasma glucose readings and potentially mislead the clinician. The key takeaway is that random blood sugar is highly practical in symptomatic patients or emergency situations. It allows rapid diagnosis and initiation of care, particularly when waiting for fasting tests is not feasible. In conclusion, we now understand how laboratory tests establish diabetes, but how do we recognize the patient's symptoms in practice and what should we look for first? This naturally leads to the next slide, where we will discuss the classic clinical signs of hyperglycemia, correlating laboratory findings with patient clinical presentation to ensure accurate and timely diagnosis. Therefore, clinical diagnosis history provided on the laboratory investigation forms plays a pivotal role in results correlation and a prerequisite requirement in ISO standard.